Hello, everyone, and welcome to our Form Health webinar, Obesity Management for the Busy Physician. My name is Dr. Lauren Lemieux, and I'm a physician at Form Health. I'm board certified in internal medicine, obesity medicine, and as a physician nutrition specialist. And my goal today is to have you leave here with some tools that you can utilize right away with your patients. Before we get started, just want to announce that this webinar is being recorded, and we encourage you to participate by asking questions or leaving comments using the chat feature in Zoom. So today we're going to explore some of the common challenges busy physicians face when providing care to patients with overweight and obesity. We'll review evidence-based recommendations for the treatment of overweight and obesity, and also highlight therapies for medical comorbidities you are already treating that can also help a patient lose weight. And finally, we'll discuss when to refer to an obesity medicine specialist. Obesity is a complex and multifactorial disease, and research has clearly demonstrated that body weight regulation is not entirely under voluntary control. There are biologic, environmental, and genetic factors that can affect weight. And one of the things that makes treating obesity difficult is that there are different factors for each individual patient. Now, we know that obesity is related to a number of different medical conditions. In fact, there's over 60 weight-related medical comorbidities, including things like cardiovascular disease, diabetes, cancer, and obstructive sleep apnea, to name a few. And obesity is one of the leading causes of morbidity and mortality in the United States. Now, for many of the obesity-related complications, weight loss can provide a significant clinical benefit. In some cases, like PCOS and infertility, this may be with as little as 2% weight loss. But in general, we're looking at about 5% body weight loss to start to see clinical benefit for many of the weight-related medical comorbidities. Now, there are many reasons why it can be difficult to talk about weight with patients. This was a survey of healthcare providers who identified that lack of time was the biggest barrier to discussing weight. Now, I do want to point out that a small percentage in this study did feel that perhaps the patient wasn't motivated or wasn't interested in weight loss. But I think it's very important that we are careful not to make these kinds of assumptions about our patients without first giving them the opportunity to have this conversation, as these beliefs that a patient isn't motivated can be harmful to them, perpetuate negative stereotypes about people with obesity, and weight bias. I also think we should be aware that we can make a difference. When discussing weight with our patients, healthcare providers can help patients increase the odds of them even attempting to lose weight, as well as the chance that they can achieve that 5% body weight loss. So we know obesity is important to talk to our patients about, but how do we do this in a busy clinic? Well, let's start with our time-saving tip number 1, which is have a plan about how you have the conversation about weight. Now, we could literally have a whole webinar just on this one topic. So in the time that we have, I'm going to go over a framework that you can utilize to help structure this conversation. And an evidence-based framework is the 5 A's. This was initially developed for use in smoking cessation counseling, but has since been adapted for weight management. And it consists of the A's: ask, assess, advise, agree, and arrange. We start by asking permission. Could we talk about your weight today? This is a respectful way to open the door for the conversation, but allowing the patient to make that decision whether or not they're ready to have it. Now, I also want to point out, before even asking this question, we should take a couple seconds to review the patient's history. There's nothing worse than starting a conversation about weight with a patient who's already lost 50, maybe even 100 pounds, and not acknowledging the success that they've had so far. When we assess our patients, this is something we do in our routine clinical practice. As it relates to obesity, we measure height and weight, calculate a BMI, measure blood pressure, but we can actually take this a step further. We can assess for contributing factors to weight gain, in particular, reviewing our medication list to see if a patient is on any weight-promoting medications. Reviewing if there are any complications that have developed as a result of the excess body weight, and also assessing a patient's readiness to change. And studies suggest this is an important step of identifying patients who will be most likely to benefit from counseling. Now, we commonly assess readiness to change by asking the question, on a scale of 1 to 10, how ready are you to make a change? And research suggests that that sweet spot is a 7 or higher. Now, if you have a patient who rates themselves as lower than a 7, it doesn't mean that the conversation's over and, okay, we'll talk about this at the next visit and move on. You can take it a step further by asking the patient, well, what would it take to bring you from, let's say, a 5 to a 7? And that way we can identify potential underlying motivators as well as obstacles for the patient. When we advise, this is utilizing motivational interviewing techniques. And one method you can consider incorporating is the ask, tell, ask method. We start off by asking a question like, what do you already know about nutritional changes to help you lose weight? Or what is one thing that you would like to change or could change? You could even ask the question, would it be all right if I shared some suggestions? And this is a way to effectively provide information while still respecting a patient's autonomy. When we tell, this is making 1 or 2 points that are simple and brief, such as highlighting how just 5% body weight loss may help the patient improve their blood pressure. And we round out the conversation by asking questions such as, what do you think about what I said? Or is that something you see yourself doing? And that also helps identify the patient's readiness to take on that plan or identify additional barriers. And furthermore, it gets the patient's buy-in moving forward with their plan as they're involved in this conversation. We then agree on the next steps of the plan, or perhaps highlight that 5% target weight loss in 3 to 6 months. And the last step is to arrange by providing resources to the patient or planning for follow-ups or referrals if that's appropriate. Now, I want to point out that there is evidence to suggest that this step of assessing readiness to change and advising is linked to an increased confidence in the patient's ability to lose weight. And when providers take that extra step of arrange, studies show that patients are more likely to have more weight loss than providers who do not perform that final step of arrangement. Now, we just went through what could be a pretty extensive conversation with the patient and their plan for weight loss. But since your time is limited, is there a way to make this a little bit more efficient? And I would argue that yes, there is. And we can do so by making use of wait time. Now, we know patients come to the waiting room, are stuck there for a while. They may be stuck in the exam room waiting for you to come in. And there's a lot of downtime that we could make use of. In particular, implementing a questionnaire could be something to help you in your clinical practice. Now, you may find it helpful to utilize a questionnaire involving questions of topics that frequently come up in your conversation with weight loss, or ways to help you identify the next steps. I have a couple examples here. One question being, which of the following have you tried in the past? Now, your patient who perhaps has just tried diet and lifestyle on their own may have a very different plan moving forward, and this conversation may be very different compared to a patient who's already tried diet and lifestyle, commercial programs, and even supplements or other medications. And that can help you focus that conversation moving forward when you're thinking about what is ultimately going to be the plan with this patient. We can also identify factors that may be affecting the patient's ability to lose weight. In particular, if appetite or cravings is identified as a major barrier, this might be a way to identify patients who would benefit from additional support with their weight loss efforts, whether that's with the lifestyle changes or considering using medications. So now let's spend a little bit more time talking about the treatment of obesity. Lifestyle changes are the foundation for weight loss, and they consist of diet, physical activity, and behavior change. But the reality is that it can be difficult for many patients to implement these on their own and or sustain them long term. And while we have seen that lifestyle changes can be effective for weight loss, for example, there are large randomized controlled trials like the Diabetes Prevention Program and Look Ahead studies that have shown that they can lead to weight loss, it is important to appreciate that in those studies, what they're really talking about are high intensity lifestyle interventions. These are defined as 14 or more sessions in a 6-month period where patients are seen in an individual or group setting by trained interventionists, and it's delivered either in person or virtually. And the interventions typically consist of a hypocaloric diet ranging from 1,200 to 1,700 calories per day, increased physical activity, and behavior change. But I'll acknowledge that for many of you, this type of model is just not feasible in your practice when seeing patients. So how can we provide another source of accountability and support for our patients when they're trying to implement lifestyle changes? Well, let's talk about some tools that you can potentially recommend. One category are those for self-monitoring. Studies have shown that self-monitoring can improve weight loss outcomes in patients, both short-term and long-term. And self-monitoring can take various forms, including weight tracking, food logging, and activity monitoring. And examples for weight tracking can be keeping a calendar next to their scale or using an app on their phone to monitor their weight. For food tracking, some patients prefer to keep a pen and paper and a journal, or they may like to use apps that can allow them to estimate their calorie intake and set a target goal for the day. And sometimes these can be useful tools to help educate the patient on what exactly is in the foods that they're eating. There are also handheld or wearable devices that are another option for patients to track their activity, potentially setting targets to reach each day. Another resource to support behavior change can be support groups, whether they're online or community-based, and they can provide a source of motivation enhancement for patients. Now, I'll just briefly mention here that at Form Health, we use a combination of self-monitoring tools like weight tracking and food logging in combination with our internet-based support materials, which are educational materials, social media support group, and webinars to increase accountability, support, and engagement among our patients, in addition to the frequent visits and messaging that they have with their care team. Now, going back to the overview of obesity treatment options, in addition to lifestyle changes, there are medications as well as bariatric surgery as two major categories of obesity treatment modalities. But it is very important to recognize that medications and surgery are done in conjunction with this foundation of lifestyle change. So what's the comparative efficacy of these interventions? With lifestyle changes, depending on the study and the intensity of the intervention, we may see anywhere from 5 to 10% body weight loss by the first year. But arguably the biggest challenge is long-term maintenance, and studies have shown this repeatedly. In fact, there was one study where they looked at patients who had lost weight, and 2 years later, they had regained about 50% of the weight that they had lost. And by 5 years, it was up to 80%. And you yourself have probably seen this in your own clinical practice many times. And is one of the reasons why we really need to think about obesity as a chronic and unfortunately relapsing disease. And I'll talk a little bit more about the mechanism behind this in just a couple minutes. When we look at pharmacotherapy, depending on the medication, we may see anywhere from 5 to 15% total body weight loss. I will point out that 15% body weight loss was observed in trials of semaglutide 2.4 milligrams, also known as Wegovy, whereas the other medications that are available are more around that 5 to 10% weight loss mark. I also want to point out that with these medications, there is the chance for weight regain after a patient stops taking them. When we talk about bariatric surgery, in the surgical literature, you'll often see weight loss reported as excess body weight loss. And the range is typically 50 to 70%, again, depending on the study that you're referring to and the procedure. And specifically, I'm referring to laparoscopic or vertical sleeve gastrectomy or Roux-en-Y gastric bypass. Now, this roughly translates to 20 to 35% total body weight loss. And bariatric surgery at this time is the most effective intervention we have for reversing obesity-related complications like diabetes. However, there are a number of reasons why a patient may not undergo surgery for weight loss. It could be they may not qualify, or it's not covered by insurance, or they're not interested. And I will share from personal experience, many patients see surgery as a last resort. But at the same time, I've also seen how many patients haven't been given the opportunity to try things beyond just diet and lifestyle changes on their own. So let's talk a little bit more about medications for weight loss and how they can be a helpful tool to our patients. And to better understand the role of medications, it's important to appreciate how there are physiologic changes that occur after we lose weight, or even while we're losing weight, where metabolism will slow down and hormones that affect satiety are altered, whereby it's very easy for patients to regain weight. And this is thought, these hormonal shifts are thought to underlie this cycle of yo-yo dieting our patients commonly experience. I also want to point out that medications are in conjunction with lifestyle changes, and research has supported that this combination is truly what can be most effective. This was a study comparing patients who received either medication alone, lifestyle counseling, brief lifestyle counseling plus medication, or intensive lifestyle counseling plus medication. And you're probably not surprised to see it was that last combination that resulted in the most amount of weight loss. Now, I will acknowledge this is an older study, and it was done with the medication called sibutramine, which is no longer on the market, but a similar effect has been demonstrated in other studies with weight loss medications. For example, in this study of liraglutide, also known as Saxenda, which is 3 milligrams, patients were given intensive behavioral therapy and randomized to receive either the medication or a placebo. And what you can see here is at 56 weeks, the addition of medication resulted in an additional 3.4% body weight loss. So who is considered a candidate for a weight loss medication? These are patients who've been unable to lose or maintain their weight with lifestyle changes alone, typically defined as a low-calorie diet with the increased physical activity. And we typically look for a threshold of losing about 5% weight loss over 3 to 6 months of implementing these lifestyle changes. It also is recommended that we follow body mass index criteria for cutoffs of using these medications, which are a body mass index of 30 or higher, or 27 or higher with a weight-related medical condition. And as I've been saying multiple times, the medications are used in conjunction with lifestyle changes. Now, there was a study that came out in 2016 that estimated approximately 46%, so almost half of adults in the United States, actually fit the criteria for use of anti-obesity medications. But it turned out only 2% received such treatment. And there are numerous reasons for why this is the case. There are concerns about the safety of the medications or efficacy, perhaps unfamiliarity with their use, and unfortunately barriers due to insurance coverage or lack thereof. But I do want to take the time to address the unfamiliarity with these medications as a barrier. And this brings me to my time-saving tip number 4, to familiarize yourself with these medications. And I look at this as a time-saving tip in the long run. It's an investment. The time you invest now to learn about these medications will save you more in the future. You won't have to spend time looking them up. You will be able to have them as a tool in your toolbox for your patients. And furthermore, if you help a patient achieve clinically significant weight loss, you're potentially reducing their need for other medications or more medical care in the future, and really helping them live their healthiest lives possible. And I would argue that most, if not all of us here, went into medicine to do just that, help our patients live a healthy life. So this is a list of the current FDA-approved medications for weight loss, with the exception of a couple stimulant medications that are not as frequently used. And I have this here as a resource for you, so feel free to take a screenshot to use this as a little cheat sheet for yourself. Of course, it doesn't contain all the information about the medications, but I wanted to highlight a key few points to get you started if you're not as familiar with them. Let's start with phentermine. Phentermine is one of the oldest medications we have for weight loss on the market. And on average, we see about 7% body weight loss at 1 year. It is a sympathomimetic medication that acts to reduce appetite and is a stimulant. And as a result, can increase heart rate and blood pressure. But I'd say the most common side effect we see is dry mouth. Now, it is available as a generic, therefore the cost is much lower. And in fact, this is probably one of the reasons why it's one of the most commonly used anti-obesity medications. Now, a medication, phentermine topiramate or Qsymia, was developed and has a lower dose of phentermine, but that addition of Qsymia, of topiramate, is another mechanism by which we can reduce appetite. Now, adding that in does result in the potential for cognitive side effects. And note that topiramate is teratogenic, so we need to be careful in utilizing this medication in women who are of reproductive age. And furthermore, it's recommended to be careful using this in patients with a history of nephrolithiasis. On average, we see about 8 to 10% body weight loss with this medication. And I'll just pause here to point out that at Form Health, our doctors do not prescribe controlled substances, so medications like phentermine and phentermine topiramate are not used by our providers. Moving on to talk about orlistat, this medication is available by prescription as Xenical or Ally over the counter. On average, we see 8.5% weight loss at 1 year, and the medication is a lipase inhibitor, so it effectively prevents the absorption of dietary fat, thereby reducing caloric intake. Not surprisingly, by blocking the absorption of fat, patients can get gastrointestinal side effects like steatorrhea, which oftentimes limits its use. And it can potentially increase the risk for vitamin deficiencies. It is contraindicated in patients with a history of oxalate nephrolithiasis. Our next medication, naltrexone bupropion, also known as Contrave, was demonstrated to result in, on average, 6.4% weight loss at 1 year and acts on appetite centers in the brain. It can increase blood pressure, and common side effects are nausea, constipation, and headache. Note importantly that the medication naltrexone cannot be used in combination with opiates, and bupropion does lower the seizure threshold. Our next two medications belong to the same group or category of medications known as GLP-1 receptor agonists, and they're some of our newest medications for weight loss on the market. GLP-1 is a hormone that our body naturally produces that helps decrease appetite by acting on appetite centers in the brain, but also acts to slow digestion, which can help people feel more full, but is also one of the reasons why there are gastrointestinal side effects like nausea and acid reflux that patients can somewhat commonly experience. There is also potential for constipation and diarrhea. And I will point out this medication, class of medications, is given by injection, and the cost is quite high, especially if not covered by insurance. It is contraindicated in patients with a history of medullary thyroid cancer, MEN2A2B syndrome, or pancreatitis. And studies have demonstrated that with liraglutide or Saxenda, on average, we saw about 9 to 11% weight loss at 1 year, whereas with semaglutide, it was up to 15%. Now, I will point out there was a more recent study that came out known as the STEP 8 trial, and this compared liraglutide, which is at a daily injection, versus semaglutide, which is a weekly injection. And this was in patients with overweight and obesity. And at 68 weeks, they found that the mean weight loss was about 15% body weight with semaglutide, but only 6.4% with liraglutide. And then the last medication I'll bring up is Plenity. On average, we see 6.4% weight loss at 24 weeks. And this medication works by physically occupying space in the stomach. So it is capsules that a patient takes with 2 large glasses of water before lunch and dinner and forms this fibrous gel that takes up about 1/4 of the stomach volume. It can cause symptoms like bloating or constipation or diarrhea, but it's also important to note that this medication is not systemically absorbed, and it's not known to cause any CNS side effects as a result. And while I have been calling it a medication, to be completely fair, it is technically classified as a medical device, not a medication. So an important point to keep in mind when utilizing medications for weight loss is there is the potential for weight regain after stopping. And this is demonstrated very clearly in this study here of semaglutide 2.4 milligrams or Wegovy, where patients were at 20 weeks randomized to either continue the semaglutide or switch over to a placebo. And importantly, you're seeing here, they're not maintaining the weight that they lost, they are regaining this weight. So this is important to understand that when we're practicing obesity management, it is really chronic disease management. An analogy is how we manage hypertension. You wouldn't stop a patient's blood pressure medication after they start taking it, and then their blood pressure normalizes, would you? So what are some considerations when choosing a weight loss medication? We're going to think about the potential efficacy of the medication, whether there are contraindications based on a patient's medical history or drug-drug interactions. What is the side effect profile and how likely is it that a patient will tolerate this medication? And is there a potential benefit for other medical comorbidities, which I'm going to talk about in just a second? We'll keep in mind patient preference and cost. So when keeping obesity in mind when treating other comorbidities, I like to think of this as effectively killing two birds with one stone. We can choose weight loss promoting medications and avoid medications that promote weight gain when we're treating other medical conditions. So an example might be there are medications for diabetes, other GLP-1 receptor agonists like liraglutide 1.8 milligrams or Victoza and semaglutide 2.0 milligrams or Ozempic, which are essentially the exact same medication as those that are FDA approved for weight loss, just at a different dose. I also wanted to point out a new medication, tirzepatide or Mounjaro. This was literally just FDA approved last week. Tirzepatide is a GIP GLP-1 agonist. GIP is thought to help augment the effects of GLP-1 by reducing appetite and further promoting weight loss. It was FDA approved for diabetes, but what we've also been seeing is that it has the significant potential for weight loss, around 22%, and currently in phase 3 clinical trials for management of obesity. So I do anticipate in the somewhat near future, this may be another tool in our toolbox for our patients for treatment of obesity. But also want to point out, of course, that obesity and type 2 diabetes are very frequently linked. When we think about patients who have concurrent depression or are smokers, we may want to think about how bupropion, which is used for treatment of depression and smoking cessation, is also an active ingredient in naltrexone bupropion or Contrave. And similarly, phentermine topiramate or Qsymia can be thought of as a potential resource for patients who have obesity and also are struggling with migraines. Now, this is a list of medications that can promote weight gain. And we don't have time to go over all of them in significant detail, but I'll just point out there are medications that can affect mood, that can increase weight. When we think about our patients with diabetes, insulin, sulfonylureas can promote weight gain. And we do have newer agents like the GLP-1 receptor agonists or SGLT2 inhibitors, an older medication like metformin that have also been shown to promote weight loss and may be another option for our patient to prevent weight gain. Furthermore, when it comes to contraception, it turns out that there's an estimate of 40% of reproductive age women have obesity. So we should really think carefully when making recommendations for contraception in this population and considering how things like Nexplanon and Depo-Provera are linked to weight gain. So this brings me to my last time-saving tip, which is knowing where and when to refer. So remember that you may not have the resources to provide extensive lifestyle counseling to your patients in your busy practice. And that's where utilizing the support of external resources like a registered dietitian may help with those lifestyle changes your patient is trying to make. However, for patients who need additional support, that might be where referral to an obesity medicine specialist might be a wonderful option for your patient. And I'll discuss this in more detail in just a moment. And then when it relates to bariatric surgery, I just want to bring your awareness that criteria for undergoing bariatric surgery is a body mass index of 40 or higher or 35 or higher with a weight-related comorbidity. So when referring to an obesity medicine specialist, this is best for patients who perhaps have been unable to lose or maintain weight loss with just lifestyle changes on their own. Perhaps they have medical comorbidities that make weight management difficult. And these are patients who would ultimately benefit from medical supervision during their weight loss efforts, and potentially including anti-obesity medications. Now, obesity medicine specialists not only have expertise in prescribing these medications and managing them, but we also have experience in potentially getting them covered and approved by insurance. And let's face it, we know how much time prior authorizations can take up. So what to look for in an obesity medicine specialist is board certification in obesity medicine, someone who follows evidence-based guidelines, provides open communication between providers, and also has effective treatment with long-term support. And I can confidently say that these are all things that you find at Form Health. So I'd like to take a moment to talk about our approach at Form Health. Patients are paired with an expert physician who's board certified in obesity medicine and an experienced registered dietitian. And together we come up with a personalized plan for your patient that involves nutrition, physical activity, and mindset shifts, and if appropriate, potentially medications. To ensure our patient's safety, we require that they've seen a primary care doctor within the last year, and we do not prescribe any controlled substances. We also aim to partner with our referring providers to be a resource for their patients, not just to lose weight, but really to live their healthiest lives. Form Health is unique in that our patients meet with us entirely virtually, and we have an app that supports the self-monitoring tools like weight tracking and food logging that studies have shown can be very effective for weight loss. Patients also have access to their care team through direct messaging, and this is truly a level of support and accountability that's unparalleled. And we've seen that our approach is effective and sustainable. On average, our patients lose close to 15% body weight by 12 months. So I want to thank you all so much for joining. For more information about Form Health, you can go to our website, formhealth.co, or to refer a patient, you can go to formhealth.co/refer-your-patient. And if you have any additional questions, you can feel free to email me directly. Though we will pause now to answer any questions that have come in through the chat, and feel free to post any as they come up as I'm speaking now. So I'll have our specialist Ehab join me to share what questions have come up during our talk.
Dr. Lauren, thank you so much for your time and for this informative presentation. We do have a couple of questions, and please feel free to ask any questions in the chat box here. We could help you with answering any questions you have. So one of the questions that we have right now, what diet should we be recommending to patients? And does really these modern fasting diets really work at the moment?
Okay. So that's a great question. When it comes to diet for weight loss, studies have shown repeatedly that it's not so much what is in the diet, but what a patient can stick with long term. And honestly, that's what our approach is when working with patients on their nutritional goals. Importantly, I will point out that yes, there are studies that show that low carbohydrate diets in that initial 3 to 6 month period may induce greater weight loss, but when you look at it in the long term, a year out, the weight loss is very similar to other means of reducing calorie intake. When it comes to intermittent fasting, there is a study that was published at the end of April in the New England Journal, and they compared a standard low calorie diet to time restricted feeding. So patients were eating during a specific interval of time, and they were also following a low calorie diet. And they found that there was no difference in terms of weight loss or fat loss or changes in cardiometabolic risk factors.
Perfect. Thank you so much. And the other question that we have is, how long should I give a weight loss medication to work before making a change?
So it's recommended that when starting a weight loss medication, we set a target of about 5% body weight loss at 3 months. And if a patient hasn't achieved that weight loss, that's where we really need to consider, all right, are we going to make a dose adjustment? For example, phentermine topiramate, there's another level of doses that you can go up to. is the medication working for the patient? Are they finding a benefit? Or if it's not helpful, are we going to switch to another agent? And I will say that unfortunately at this time, we don't have a lot of great studies looking at combinations of anti-obesity medications, but it is hopeful that we will have more of these in the future to better guide our treatment of our patients.
Okay, thank you. And a couple of other questions that I have here is, how can I learn more about obesity medicine?
Okay. There are a number of professional organizations that provide annual conferences and educational materials, two of which I would recommend would be the Obesity Society and the Obesity Medicine Association.
And I'm going to take the last question that we have over here is, how often do patients meet with the providers at firm?
Okay, so patients meet with their doctor approximately every 4 weeks and a dietitian every 2 weeks. And we found that this is a real sweet spot for the frequency of visits, because it allows us to have that close contact with patients and keep them on track. And they find that it works really well.
Okay, I think that's all the questions that we had for today. There is no more questions.
Great. Well, I just want to thank everyone so much for joining today and taking the time out of your busy schedules to participate. My email is listed here if you have any further questions that come up. And if you're interested in partnering with us, feel free to reach out as well. But hope you enjoy the rest of your day.